Thanks, Premier. Basically, just trending down across the board. Obviously, an overall increase today of 33 with some reclassified cases. That's the lowest we've seen for weeks and weeks. The numbers in hospital in ICU on ventilators are at their lowest level for several weeks as well. The same applies to active cases, now down to 1,251, and as the Premier said, really on track in regional Victoria to hit the targets that will allow a jump of a step and to significantly open up, all things being well, over the next few days in terms of not having cases that have unknown acquisition or mystery cases, but they have gone a significant period without that. They're obviously at a daily average which is below 5 and with every expectation it'll remain there. That said, there are a few hundred cases that are a few hundred close contacts of those active cases, and they'll need to go through their 14-day period. So there might be some additional cases that we can and should expect in regional Victoria, but we want them to be associated with known active cases or known outbreaks, so that we can be satisfied that we're tracking each and every one of them and that there aren't these further mystery cases. But it's absolutely on the right track, and everything that regional Victoria has achieved is of their own doing, following the rules and really putting up with these significant constrictions has got them to the point that they're at now, and with a pretty positive path ahead. They've been supported by everything that's been done in Metro Melbourne, because the number of cases that are linked back to Metro Melbourne has decreased very significantly over time. So there are lessons there for us here in Melbourne, that you can go from 512 active cases in regional Victoria to numbers in the 50s and be on track to have no new cases over the coming fortnight. That is not beyond the possibility, and Metro Melbourne is also tracking extremely well in that regard, which is showing up in how our health services are eased and the number of active healthcare workers dropping below 200. And the number in aged care also well down on where it's been in recent weeks. Thank you.
What is that number on aged care? I'm not sure whether the Premier is.
Active cases in aged care. You've got it? 625.
Professor, in a nutshell, can you explain what is the final trigger for you for pulling the trigger on changes in regionals? What is the final bit of information you need? And also, in a nutshell, can you explain if they jump 2 steps, what does it mean they'll be able to do?
So really, we've laid out those thresholds, which is being below 5 new cases per day over a 14-day period. It's below that now. They would need to have significantly more than 5 in the remaining days for it to head up above 5 again, and for there to be no mystery cases or cases of unknown acquisition in that same 14-day period. When they meet that target, they don't just go to what was flagged for changes for September 14, but to significant operational changes that the Premier's listed some of today.
And do you treat those really small towns that have obviously never had any cases at all the same as somewhere like Geelong?
I think we have to. I think we need to recognise that we only know about cases that are notified. Cases that are notified are only about people who step up for testing, and there can be cases out there that are not known to us because people haven't tested, because they've had very mild symptoms and haven't sought care and sought testing. So even if there have been areas with no cases, they'll be treated the same as the rest of regional Victoria. But the wins are for the whole of regional Victoria, because they've been under these restrictions and it's driven transmission down. And there have probably been cases there that have never been discovered, but those chains of transmission have nonetheless ended because these restrictions have been in place.
So will the decision be made on Monday for this?
Look, I think we can follow each and every day. We'll need to absolutely get to Monday to see that. I don't think we could call it today, for example. I do think we have to go through the weekend, see Monday, make sure that there are either no new cases, and if there are new cases, that we can really rapidly ascertain where they've acquired it, and hopefully they're in known close contacts of active cases, so that we can link them immediately and we know that they're contained.
And so when's the soonest do you think that they could have those two steps taken?
Well, we'll write the public health directions as soon as possible after that time, but we do need to be assured that they've met that threshold in the first instance.
Professor, the team of Victorians that's arrived in New South Wales to talk about contact tracing,
Yep.
has any information flowed back as yet?
No, look, nothing back immediately. I think it was a very constructive time spent on both sides. There are lessons to learn for New South Wales as for Victoria. As I've said earlier, there are things in Victoria that we're doing better than anyone. I think Operation Vestige, where the door knocks are occurring immediately for close contacts and for cases, is a very useful addition to all of the telephone follow-up of cases and close contacts, both for those who haven't picked up the phone or who we haven't been able to reach, but also as that routine and regular check-in, sometimes to complete some details of the interview that couldn't be completed over the phone. So I am sure that there'll be lessons learned for us, but the same for New South Wales, no doubt.
The team at Melbourne Uni who did the modelling, they say they've been misrepresented and they're asking for changes because they don't think these targets are attainable.
Well, it's not us representing University of Melbourne. If they've been misrepresented, it's in assuming that the only inputs into the policy decisions that we've made and the thresholds that we've made has been based on that modelling. That modelling was a really significant and core input into decision making for policy decisions, but it was by no means the only one. There have been lots of other inputs, and of course it's been the experience of watching the numbers both here and in other jurisdictions to see the kind of levels you need to get to be happy that you can sustain those very low levels of transmission or get to no transmission if you can.
They say the only place where that has worked to get down to those targets has been Wuhan. That's got to be alarming.
No, I don't think that's true. Wuhan obviously had very significant numbers, but they got to 80,000 cases in that city. We're not at that level. We're not going to get to that level, so we're in a better position in that regard. And there are jurisdictions, island states essentially, with lower numbers than we've gotten to, who got to the point where they have had long-term maintenance of very low numbers or gotten to no community transmission. But we're at a point now where we're at 30 odd cases a day. So it is within our grasp, and we'll be realistic about how it's tracking. We won't just say the modelling tells us this and we will move at this point. We will follow those numbers every day. If we get to a point where it is clear that it is not possible to get to no community transmission, we'll make a call on that. And it is also possible that we will get to a point where the numbers are higher, but we will investigate those numbers, we'll see where they're occurring, why they're occurring and how they're occurring, and make a judgment about whether 5 is the appropriate target, or if it's 10 cases a day, but 8 of them are in aged care, and that's not inconceivable, that we will absolutely focus our attention on containing all transmission within aged care, but otherwise lifting for the community. But they're judgments to make down the track, and we'll do it on the basis of how things are going over the next few weeks.
The suggestion from this epidemiologist is that instead of that 5 being the threshold, move it to 10, and that makes it a little bit more realistic, potentially sooner. But the difference between the percentage of risk of a third wave coming through isn't that much. Can you explain if that's actually the case?
Well, I think that the judgments that we're making are based on the modelling, but other experience in Australia and internationally. And again, the risk tolerance you might get to will be different for different people, but the risk of a third wave is not one that you would want to tolerate at 60%. You wouldn't want to flip a coin on it. You probably wouldn't want it at 20% because of what it means to get there. But I'm talking to Tony this afternoon. We will sit down, we will make further revisions of modelling, and we'll re-prosecute the inputs and the assumptions and follow the real data as we go, and we can make judgments that are different at different points in time. But the importance of the roadmap was to lay out some general movements in those directions and to have some really strong indicative numbers so that people understood where we were heading. And people might have said that regional Victoria was not going to get to this point this week or next week, but here we are.
So when you say that you'll make further revisions after speaking with Professor Blakely later, are you saying that potentially the triggers that we saw in the roadmap last week could be changed?
Well, it's entirely possible that the new inputs into modelling, and they're always informed by changes in what we see on a day-to-day basis. And so there might be new probabilities that are generated in that modelling. We'd reflect on that and we would make changes as appropriate.
New South Wales recorded 24,000 tests on Thursday, the 24 hours to Thursday, and we are about 10,000 fewer than that. Can we have confidence in the low numbers?
We'd certainly like a lot of testing to be done. I think we've been doing such a fantastic job, and testing really is our pathway out of this. So we have to know where cases are to be able to control this, and there is a risk when people don't test and when transmission occurs, or if it's delayed, that you can get these significant outbreaks. And that will be true in regional Victoria as for Metro Melbourne. So absolutely we'd encourage it across the board in Victoria. And I'd say particularly for regional Victoria to protect it, because there are still essential workers, there are still people who move into Metro Melbourne for essential reasons. So anyone who's symptomatic, but I would call out anyone who is coming into Metro Melbourne for essential reasons, if they develop symptoms, to be acutely aware of the need for testing, because we will get on top of it very early if people test. So absolutely encourage further testing.
Is there a figure that you consider to be the right number of tests to be giving the right indication or an accurate indication of how widespread it is?
Not really. Look, I'd be disappointed if it stayed below 10,000. I'd be happy if it were above 20,000. But there's no absolute magic number there. It is about having an appropriate match of where transmission is highest to make sure that testing is really good in those areas. And we've had some cases recently in Hobsons Bay, in Hallam. I'd encourage people in those areas in particular where we've called out some cases to particularly step forward for testing, but we do want a baseline level of testing across the board, because you never know if there's a case out there that hasn't been detected.
Professor Sutton, you were quoted in the Saturday paper as describing a contact tracing system as a total hodgepodge of private and public providers that are not able to be stewarded centrally. We've seen failures in outsourcing hotel quarantine to the private sector as well. Would you prefer to see the money coming in-house to the Department of Health?
So that wasn't about contact tracing. That was about the fact that there are private pathology providers who operate across Victoria, and we've worked extremely hard to align the testing that's being done across those providers so that the turnaround times, which have come down significantly from a couple of days to under 1 day for the majority of people now. So it is improving, but it wasn't a comment about contact tracing at all. And I think the idea that you wouldn't go to external providers for additional surge capacity is silly. You would absolutely go to external providers when you need a surge capability, and that's what we've done. And the Whisper system is an example of an IT innovation that made a big difference in contact tracing early on, from March onwards in Victoria.
You said yourself that even at lower numbers there were some intrinsic challenges with contact tracing. Do you think those have been resolved?
Well, we've always talked about the improvements that have been made over time, so it's not news, to be fair, that we're at a better point now than we've been at any other point with contact tracing. So those challenges have been spoken to in some of the improvements that we've made in recent weeks, which include IT improvements, but also the beefing up of numbers of people who are on the phones, who are doing interviews, the way that notifications come in and the like. So I think we're absolutely in a better position. But we had to move through that. That was, there were complexities to work through, and it takes time and effort to get to that point.
Can you explain the thinking behind realigning beauty services and personal services with hairdressing? There has been a lot of outcry in the community saying they were the ones that have all these really strict hygiene measures already in place, perhaps even more than hairdressers. How come a rethink?
Well, certainly hairdressing had been a decision of National Cabinet. There was obviously a view that it was an important service to provide. Everyone understood that it was there was a certain risk associated with it because of the close contacts between a hairdresser and a client. The same challenges apply in personal care and body art services, but we did want to really investigate what those risks were, what the experience of outbreaks or transmission were in Victoria, but also internationally. And the fact is that if both the client and the service provider can wear masks, then you really significantly mitigate that risk. And there are some services like manicures and pedicures that won't be a very long period of time, even in comparison to hairdressing. So, we think on a relative scale of risk, and because local government registers these settings and environmental health officers can inspect as well as WorkSafe, and that there's a register of names of clients who attend, that all of these things in place really means that it should be lifted up to the same level as hairdressing in terms of coming in at that step 3.
In terms of continuing to monitor the thresholds, has anything changed in terms of when the roadmap was first outlined? It seems as though the 5 cases is moving more than it had been a week ago. Is that the case, and if so, why?
No, I don't think so. But in talking to the modellers, and we've spoken to not just the University of Melbourne modellers, but modellers at Burnett Institute and the Peter Doherty Institute. They shared lots of insights, and they want to have an ongoing conversation with each other and with us. But one of the things that Uni Melbourne reflected on was that they can't easily dig into different transmission for subpopulations within a broad Victorian population. Their modelling kind of makes a homogenous, one size fits all. With individuals with different characteristics, it's an agent-based model that says, here's an infectious person on day 1, here's a less infectious person on day 5, people of different age moving together in different ways, but they haven't gone to some of the realities in Victoria in terms of our aged care transmission. And I think that's another step to input into the model as best can be done. They need to access the data and to be confident that it's telling the right story there. So we'll continue to investigate it. But there's no significant shift on the 5 at the moment. I think we can get there, but we should be realistic about following the numbers, not just following the modelling.
Do you think contact tracing in aged care settings has been successful?
I think in a way contact tracing doesn't happen in aged care. You get the first notification in a staff member or in a resident, and then everyone is in lockdown effectively, and then everyone is tested immediately, and then there's day 11 testing for everyone as well. So the most critical step for aged care is for anyone who's symptomatic to get tested as soon as possible. And that hasn't always happened quickly, and we want to absolutely encourage staff in those facilities and for surveillance of residents so that people can be tested at the earliest possible symptoms. But in terms of notification to us and to the facility that there's an outbreak with one case, that's happening at the same time as notifications are coming in. But the challenge is, if someone has been symptomatic for 3 days, if a resident's been symptomatic for 3 days and potentially wandering around, that's a lot of transmission before it's even been notified. So we need to shorten those times as much as possible.
Professor, I'm not sure if this is a question better for you or the Premier or both, but who set the 5 target for the easing of the most stringent lockdown?
Look, it's the advice of the public health team that I lead. But it's a discussion with Cabinet, and I think the Premier can speak to the broader decision making around that. But we obviously reflected on a whole number of things, and there were some recommendations that the public health team made from that point of view.
Premier? Sure.
I've said many times this week.
Thanks.
You're always here. You're here as much as I am.
Thanks, guys.
Thank you.